Good morning, everyone. I'm Qian Ding from Shanghai Force People's Hospital. Today, I'm pleased to present a case that highlights the intersection of viral myocarditis and thrombotic tendency, a challenging scenario that demands our full clinical attention. Viral myocarditis is a well-known cardiac disorder, but when it occurs with a prothrombotic state, the clinical picture becomes far more complicated. In this talk, I will walk you through a case that illustrates this dual threat and discuss the lesson we learned. Common pathogens responsible for viral myocarditis include Epstein-Barr virus and cytomegalovirus. Both are ubiquitous, but their cardiac involvement can be severe, especially in immunocompetent hosts, as we will see. Viral infection triggers cascades of inflammatory cytokines, particularly IL-6 and TNF-alpha, which in turn induce a hypercoagulable state. This inflammatory thrombotic axis is a key driver of adverse outcomes. Beyond infection, genetic predisposition matters. Mutations in the MTHFR gene and the PAI-1 gene are known risk factors for thrombophilia. They impair normal hemostasis and fibrinolysis, respectively, increasing the likelihood of clot formation. Despite these insights, the mechanism between viral infection and genetic thrombophilia remains poorly understood. How these factors interact to cause multi-organ embolism is still an open question, and management guidelines are lacking. Now, let me introduce the patient. A 43-year-old male presented with a 1-month history of exertional dyspnea, a 2-week history of cough and fever, and hemoptysis for 2 days. These progressive symptoms raised immediate concern. He had a 20-year history of hypertension and weighed 98 kg. On admission, physical examination revealed jugular venous distension, positive hepatojugular reflex, and severe lower extremity edema, onset of right heart failure. CTA showed bilateral lower pulmonary artery thrombi with pulmonary infection. Importantly, antiphospholipid antibodies, influenza A and B, and SARS-CoV-2 were all negative, ruling out common autoimmune and infections mimics. On hospital day 4, anticoagulography detected a left ventricular thrombus and a LEVF of only 42%. This was turning point, confirming that the disease was not conformed to pulmonary circulation. By day 7, genetic testing revealed MTHFR C677T, heterozygoity, and PAI-1 4G and 5G polymorphism. These findings confirm that inherited thrombophilia background, which would later prove crucial for management. Cardiac MRI on day 10 showed that LEVF had dropped further to 26.5%, indicating severe myocardial dysfunction. At this point, we knew we were dealing with a life-threatening condition. Interestingly, the diagnosis of viral myocarditis was confirmed by next-generation sequence of pleural fluid obtained on day 1, The results were positive for both EBV and CMV, in establishing the etiology. On the same day as the first ankle, the patient developed acute right side limb weakness. Brain imaging showed multiple cerebral infarcts without large vessel occlusion, consistent with cardioembolic or hypercoagulability revealed strokes. By day 20, follow-up cardiac imaging demonstrated reduced motion of the left ventricular lateral, inferior posterior walls, and apex, a pattern typical of extensive myocarditis. On day 33, myocardial biopsy results supported the viral myocarditis diagnosis. At the same time, ultrasound showed significant regression of ventricular thrombi, with LEVF recovering to 53% and IVS thickness normalizing at 7 clever evidence of therapeutic success. During the initial 1 to 7 days, we initiated target thrombus therapy with low molecular weight heparin, given the confirmed bilateral pulmonary artery thrombi and pulmonary infarction. This was the cornerstone of early anticoagulation. Concurrently, we used diuretics to review heart failure symptoms. This supportive measure helped reduce fluid overload and improve the patient's clinical status during the acute phase. For the viral infection, we started intravenous methylprednisolone 100 mg twice daily, then switched to oral prednisone 1 mg/kg per day with a gradual taper. This immunosuppressive regimen was aimed to controlling myocardial inflammation. To stabilize cardiac function, we maintained strict volume control, adjusted fluid intake and output, and continued diuretic therapy. These measures reduced cardiac burden and supported recovery until the patient met discharge criteria. By day 33, LEVF had increased to 53% with obvious thrombus regression. This favorable response validated our multidisciplinary approach and gave us confidence in the treatment plan. After discharge, warfarin was switched to rivaroxaban because of unstable IR levels, which ranged from 1.11 to 7.43. The switch improved anticoagulation control and reduced bleeding risk. At 6 months, the patient had normal cardiac function and no recurrent thrombosis. This long-term success underscores the importance of personalized follow-up and timely therapy adjustment. Looking at LEVF data, virals during early admissions range from 26.5% to 42%. After treatment, they rose significantly to 53 to 54.9% during follow-up, a dramatic and gratifying improvement. Thrombi were initially present in the pulmonary arteries, left ventricle, and brain. By follow-up, all were reported as resolved, indicating successful treatment of both infection and hypercoagulable state. INR control was highly unstable early on, with values fluctuating between 1.11 and 7.43. After switching to rivaroxaban, INR becomes stable, demonstrating better anticoagulation management in the later phase. Mechanistically, viruses cause direct myocardial injury and also trigger cytokine storm. This storm activates coagulation, exacerbating damage beyond the heart, a vicious cycle that we must recognize and interrupt. Genetic mutation MTHFR and PAI-1 further disrupt endothelial integrity and fibrinosis. In this case, the viral infection and genetic predisposition didn't act independently. Instead, they formed a vicious cycle. We called it virus inflammation gene cycle. The virus triggers inflammation, inflammation promotes a hypercoagulable state, and the genetic defects impair fibrinosis. Each component worsens the others. This interplay amplifies the overall harm, eventually leading to widespread blood clots that affect not just the heart, but also the lungs and the brain. In a sense, the scenario is far greater than the sum of these parts. Diagnosing this condition poses significant challenges. Myocardial biopsy, though the gold standard, is often delayed because of clinical instability. Moreover, early use of glucocorticoids may mask the underlying pathological findings, leading to false negative results. To overcome these hurdles, we recommend an active diagnostic strategy. Early multi-specimen next-generation sequencing, including blood, bronchoalveolar lavage fluids, myocardial tissue, and pleural fluids, combined with dynamic viral DNA load monitoring. This approach can substantially increase the diagnostic yield and guide timely therapeutic decisions. Managing anticoagulation in this patient was particularly demanding. For drug selection, we started with weight-based low molecular weight heparin and then transitioned to warfarin, which thus carefully adjusted in the context of MTHFR mutation. However, warfarin resulted in poor NR control, so a treatment switch became necessary. We successfully changed to rivaroxaban, which stabilized the anticoagulation effect. Regarding acute management, a critical lesson is that during acute cerebral infection, we must temporarily hold anticoagulation to avoid hemorrhagic transformation, while closely monitoring neurological states and any signs of bleeding. What caused this catastrophic presentation? The infection cause was dual, both EBV and CMV were identified. When this dual viral infection combines with hereditary thrombophilia, it creates a perfect storm for severe multi-organ embolism. This highlights the urgent need for clinical awareness. As clinicians, we must maintain a high index of suspicion for such coexistent conditions, especially in young to middle-aged patients presenting with both cardiac and thrombotic manifestations. This brings us to the importance of early screening. Early pathogen screening is crucial. It allows us to identify the virus promptly and initiate antiviral and immunomodulatory therapy without delay, thereby preventing severe multi-organ embolism and improving outcomes. Equally important is genetic screening. Detecting hereditary thrombophilia such as MTHFR and PAI-1 mutations enables us to tailor anticoagulation according to patient's individual risk profile, effectively preventing recurrent embolic events. Anticoagulation is a double-edged sword. The first key point is an anticoagulation balance. We must carefully weigh the risk of thrombosis against the risk of bleeding through a personalized treatment approach, taking into account the patient's weight, genotype, neural function, and concomitant medications. The second is therapy tailoring. When the initial regimen, such as warfarin, falls on due to uncontrollable INR fluctuations, we should not hesitate to switch to a direct oral anticoagulation like rivaroxaban, which provides more effective and stable risk management. Managing such a critical ill patient is never a solo effort. Multidisciplinary care is indispensable. This involves close specialist cooperation among cardiology, hematology, and neurology. Each discipline contributes its expertise to ensure comprehensive assessment and treatment. For severe cases of multi-organ embolism arising from EBV and CMV infection and hereditary thrombophilia, this collaborative approach is truly crucial. It allows us to adjust the cardiac, hematological, and neurological aspects simultaneously and to optimize patient outcomes. In early phase during the acute hospital stay, the approach was to start with non-molecular weight heparin and then transition to warfarin with close IR monitoring and dose adjustment. Then, in the follow-up phase after discharge, we changed the medication to rivaroxaban, continuously adapting the anticoagulant strategy to patient's stable chronic condition. This phased plan ensured both acute efficiency and long-term safety. Finally, I would like to thank you all of you for your attention and interest. We welcome your questions and comments. Thank you.